This is Dr. Ravi Kamepalli. I'm an infectious disease, wound care, and obesity medicine doctor in Georgia. We're going to discuss a case on this World Health Day, which is a case of glucose and ketone metabolic flux. Dr. Kraft designed glucose and insulin testing, which he modified the pregnancy test of glucose tolerance test and added insulin. So what we are seeing in our clinic is also use of continuous glucose monitoring along with use of ketone and glucose testing will help the patients understand the metabolic flux that is involved in reactive hypoglycemia. So that's why we did this, and I wanted to present this case. We're located in LaGrange area in Georgia. Our website is nobadbugs.com, and X handle is at wound physician. Removing barriers to healing is what we do, and we don't have much of any disclosure except that we're developing a comprehensive solution for telemedicine based application that would help improve clinical outcome and help patients with infectious disease, wounds, and obesity. So let's dive in. Basically, we have a patient who is 56-year-old female with history of muscle pain, joint pains, and jaw pain, and diffuse pinprick sensation. Had history of COVID in the past, and had fatigue and episodes of low blood pressure, and has a history of taking allergy shots. She had history of some tick bites, and one of the reasons for the referral was possibility of Rocky Mountain spotted fever, but that was negative. But even then, she was treated empirically before she presented to see us. Her weight has been low at 120 pounds, and essentially she has had history of endometrial hyperplasia and history of hysterectomy, and maternal malformation, which is normally seen on the left side. She had it on the right side as per the previous medical vascular professionals. She had heart palpitation in 2017, and suspecting problems with hypoglycemia, we did give her continuous glucose monitoring in February. She presented in March, again early March, and decision was made to do a glucose tolerance test with insulin that was done with Kraft testing done on March 14th. And prior to that, during the CGM episodes also, she had problems with dry eyes, fatigue, arthritic symptoms. And unfortunately, at the end of March of 2025, she did end up having COVID again. So if you can see here, she has episodes of hypoglycemia that are recorded and evident. And during the Kraft testing of glucose tolerance testing, glucose load was given, and her baseline insulin was 3.5. But within 30 minutes, it went to 38, and she ended up having also issues with symptoms during this glycemic and load and insulin spike. If you see, this insulin levels were high until 23.3, with the 4-hour insulin levels coming down to 27, but glucose came down. So we did see that her highest glucose was 167 on the blood draw, but when we had added CGM, it was noted to be 220, and within 4 hours it went steep down to 54, whereas with the blood draw it was only 68. So also we added, this is a modification apart from CGM we added, wherein we asked her to do a glucose and ketone monitoring, which is we tested that glucose also on the Keto Mojo device was used, and which is a glucose ketone meter. If you can see, this ketones dropped here in the beige color, and there's a nice curve here of glucose spike and reduction of ketones, and also glucose ketone index, which is one of the parameters that was noted to be spiking up, and it is noted to the elevated glucose ketone index is not a good thing. And basically her baseline glucose ketone index, which is a comparison of glucose and ketone, was 5.8, which is single digit numbers is what I want for metabolic health. Once, if there is any cancer or severe diseases, then it has to be almost 2 or less. But here in GKI, she was 5.8 for metabolic health. That should be fine. But that it depends upon the flux of fatty acid metabolism, that's what ketone production increased, and the GKI is reduced in the combination of glucose ketone index. If you see how glucose ketone index increased, and even in the HOMA-IR score, which is normally seen as one of the application to see if elevated HOMA-IR score increase, glycemic variability is noted to show, and increased HOMA-IR is correlated with cardiac diseases also. We did lab work which showed that our lipid profile was 241. Our non-HDL cholesterol was 165. NMR lipid profile was normal with except for LDL particles that were 1,581. The triglycerides to HDL ratio was normal, and LPIR score and apolipoprotein B and A1 are noted to be 186 and 108, and LP-little 41.8, and uric acid level 4.6, and hemoglobin A1C was 5.3. So C-peptide and insulin were done, with C-peptide showing 0.7, and hence we did insulin antibodies. They are negative, and fasting insulin was 2.5. Even mitochondrial antibodies were negative. We did thyroid antibody testing also. So this is a body composition test. We'll go through that in a bit. And we did microvascular study, which body with ABI, with sweat testing, with pseudomotor function showing additional tools, with lower extremities showing increased sweating. So that is peripheral autonomic neuropathy, which the rest of the ABIs are normal. And these autonomic changes happen when the people have hypoglycemia, that is neurohypoglycemia, leading to the stimulation of hypothalamus, causing sympathetic nerve stimulation, causing muscle tremor, or adrenal medulla problems with adrenaline being secreted, leading to muscle tremor, heart problems with pounding heart and palpitations, and also pseudomotor exocrine sweat gland sweating. So in diagnosis of reactive hypoglycemia, it is diagnosed with clinical observation. Mostly there is something called as Whipple's triad, with which involves symptoms and hypoglycemia, shakiness, sweating, confusion, clumsiness, and also blood sugars below 70 during symptoms, and the symptoms getting resolved. These are the Whipple's triad for reactive hypoglycemia, which is detected by GTT with mixed meal testing and CGM or fasting studies. And reactive hypoglycemia can be distinguished from other conditions, including insulinoma, non-insulin pancreatogenesis hypoglycemia syndrome, and hormonal deficiencies and fictitious hypoglycemia, and alimentary hypoglycemia. So this is a review of patients, a small study where they reviewed patients that noted that in reactive hypoglycemic patients are more prevalent in obese patients, and that is linked to insulin resistance, and that could be detected because of oral glucose tolerance test. And in this patients, basically in patients who had severe hypoglycemia, 17.4% of them were obese participants, where the blood sugar went down to 50. And basically significant differences emerged at 3 to 4 hours after this one. And insulin resistance mechanisms at 4 hours in obese patients, where insulin levels went 4 times higher than normal weight group. And HOMA-IR testing was increased with people who are obese, higher BMI. But as you can see here, in this patient, the HOMA-IR went up even though she is lean and low BMI, even less than 20. So it is a significant study which showed that obese patients postprandially have symptoms, and obviously intervention involved focusing on weight management. And this was a small study. Sample was only 34, and obviously this was targeting obese patients with reactive hypoglycemia. And in short, they said that's what the finding of this review was. But the intervention involved lifestyle changes, adopting low carbohydrate, therapeutic carbohydrate restriction with the ketogenic diet. Ketogenic diet, I want people to understand that, is not a meat diet. It's a diet where human body produces ketones as oxidation byproduct of fat oxidation. That is, fat is used, and that's the only way in which fat mass is reduced. So basically, we need to modify the diabetic drugs, and occurrence of hyperinsulinemia was noted, and basically we need to address insulin resistance and frequent hypoglycemia symptoms, and to reduce the cardiovascular risk and development of diabetes. So the crux of this study, this case, is for us to understand the hybrid metabolic analogy in humans. Humans are like hybrid animals, wherein the primary pure fuel is glucose. It's a quick fuel like gasoline in a hybrid car, whereas the ketones are the super fuel from fat oxidation and sustained energy that comes from it. It's like switching efficiency is not there. Like it's healthy in a healthy individual, there's a easy flux between glucose and fat fuel, whereas in reactive hypoglycemia, there is impaired switching that happens in hybrid car when there is stalling, unable to switch from gasoline mode to electric mode. And obviously, insulin dysregulation, excessive insulin secretion, post-carbohydrate intake suppresses fat oxidation, limiting ketone availability. That is the insulin dysregulation that happens in these people when there is a metabolic flux in reactive hypoglycemia, wherein the glucose flux in a postprandial state is wherein there is a rapid glucose shoot and there is suppressed insulin inhibition and hypoglycemia phase. During hypoglycemia phase, there is insufficient hepatic glucose production. So ketones mostly are produced in the liver, and that's where ketogenesis happens. And basically in fatty liver, that's a problem. It doesn't happen there. So in delayed ketogenesis exacerbates the energy deficit leading to hypoglycemia, and glucose flux is volatile with high glucose and sudden crashes and stabilizing, but underutilized. This is underutilized approach. So dietarily, we need to avoid refined carbohydrates to minimize the glucose spikes and increase fat and protein intake to promote ketone production. And metabolic flexibility is key. A prolonged fasting or low carbohydrate diet enhance ketone adaptation, improving the fuel switch capacity. Avoiding snacking is key, and which perpetuates glucose dependency. And basically, the key contrast between in ketones in nutritional ketosis and ketotic hypoglycemia, which is that happens in ketoacidosis, is wherein there is reactive hypoglycemia. In reactive hypoglycemia, there is postprandial drive by insulin dysregulation, poor ketone mobilization, whereas ketotic hypoglycemia, there is fasting induced and involves physiological and pathological ketosis of glycogen depletion. So in ketogenic hypoglycemia, that is in ketoacidosis conditions, the glycogen depletion happens, which is very common, and that's when ketoacidosis is occurring. So in this patient, basically she has a significant lean mass loss. So the goal is to increase the lean mass and have her encourage food logging, trying to track food logging and glycemic response, and empowering her with continuous glucose monitor and glucose ketone monitor. Give her creatine supplementation twice a day, and urolithin A supplementation. And we are using a platform-based approach, using telemedicine and health coaching and integrated monitoring, using the platform that we have been using in the last 2 years called collegomed.com. And we are empowering the solution and guiding the patient in improving body composition and symptoms in a team-based manner using health coaches. The problem with healthcare is there has been a lip service in a diet, as just telling them to improve their diet is not going to help. We need actionable steps using high-touch, compassionate solutions. As the concept of diet versus disease is being replaced by diet versus a drug in the current medical practice guidelines and with the new GLP-1 agonist. So we have to understand that this whole process needs improvement, and we need to empower each patient. Please see the patient's perspective in addition to this that is available. That could help you understand the patient side of the story. And please reach out to us if you have any questions. Our website, nobadbugs.com, and our Twitter handle @OnePhysician, and removing barriers to healing is our hashtag that we use. Thank you very much.